Very nice presentation. Thanks for the data. I have a question. What's the rationale of talking about the peak pressure during a spontaneous mode and consider it protective? Because you don't know what is the actual pressure that the patient is developing, so the transpulmonary distending pressure, you cannot really control that. I mean, just by saying that the peak pressure is below 30, to me is not a very useful information.
That's right. We don't have this data like for the tidal volume, but if you look at the analysis of the ARDS network, and if you have a look at mortality and peak pressure, maybe you can interpret it like you want, but if you use low peak pressures, it's more protective than high peak pressures. I guess that's my interpretation of it. We have not a hard cut-off, of course, and with different patients, but I guess if we spare peak pressure, patients will profit from it.
No, I'm meaning something else. During spontaneous breathing, you have negative intrathoracic pressure development by the muscles, and you have the positive pressure by the ventilator. So the two pressures are distending the lung. So by just having one pressure, you don't have the other. You know, in the ARDS net, this is control, and then it is only the positive pressure of the ventilator.
Yeah, maybe we need an esophageal pressure for it to answer this question, but this was impossible. Too many lines in the patient.
You could use a poor man's pressure with just only do an inspiratory occlusion.
Yeah, that's good.
That's you get that pressure. So that's the patient pressure. But I think also what you say about the ARDS trial, I mean, every patient in the low tidal volume group were huffing and puffing away at the breathing frequency of 30. So they were definitely not having just that peak pressure either. They had their own pressures on top. The other group that was at 15 breaths per minute, they were probably so hyperventilated that they did not breathe.
Are there any other questions from the audience? Christian, we recently had a patient with HN1 and also on ECMO, and we ended up titrating the sweep gas flow based on a reasonable AD signal for that patient. And what we actually saw that was changing it with 1 or 2 liters actually made a huge difference. So what do you think about that?
Yeah, it does indeed, especially with H1N1 in the winters it made. But what did you also put your patient on NAVA with the ECMO system?
Yeah, patient was on NAVA, and when CO2 increased even from 6.3 to 6.7 without an evident change in his pH, then he had huge ED signals and large tidal volumes. And when we increased sweep gas a little bit and CO2 went back to 6.3, then it was all over.
It's impressive if you stand beside the bed. If you turn the sweep gas flow and you have a response within, we see the same response within seconds or within the first minute. But I cannot say if it's a CO2 or the pH value, because with this setting you cannot distinguish it. This is my problem. We thought it several times, how can you distinguish between pH value and CO2? Maybe with patients who have a severe renal failure, you cannot compensate. Maybe we get some ideas from those patients because they cannot compensate. But I'm not sure if it's a CO2 or if it's a pH value.
Right.
Thank you. I have a question about, you said that the patients who had tidal volumes greater than 6 ml probably were the sicker patients, and those might use ECMO on NAVA. You could equally argue that if their control system is working, that the ones who had larger than 6 ml actually were less sick, and they maintain that 6 ml. So do you have any other measures of severity to address which hypothesis is the correct one, whether it be PF or compliance? Were those patients the one with the lower compliance or higher compliance?
That's right. Those were more the patients with a higher compliance, as I agree totally with you. One of this with a very low tidal volumes we had the average compliance of the respiratory system was around about 25 or 22 of our patients, and those one you heard correctly. That was the one with a higher compliance.
So those patients with a tidal volume of 7 may not be the ones you have to put on ECMO, in fact.
Okay, I think we have to finish and go on with the round table again. So.